So, good evening, everyone, and welcome to the EUROGEN webinar series. We're starting up again in 2025. And just before we get going with tonight's presentations, I'd just like to take a couple of minutes to explain a little bit about what EUROGEN is and does. EUROGEN is one of 24 European reference networks created and funded by the European Commission, and they were set up in 2017. There are 24 reference networks covering most medical fields. And at the moment, EUROGEN is a network of 56 hospitals in 20 member states. And we're all collaborating together to deliver quicker specialist evaluation and more equitable access to high-quality diagnosis, treatment and care for patients with rare urogenital diseases and complex conditions that all require highly specialised healthcare. And it's really where the expertise is rare. We're focusing on the surgery. Some of the activities, I hope you noticed from the beginning slides, one of them is we can conduct virtual cross-border consultations using a secure IT platform provided to all the ERNs by the European Commission. So we can, if you have a complex or tricky case, we can put you in touch with our experts and provide advice. And this is completely free and available to any healthcare professional working in the European Union. So along with virtual consultations, we also collaborate on education and training activities like this webinar, and we also produce clinical guidelines together. And finally, we also have a EUROGEN patient registry, which is very exciting, being rolled out across hopefully all our healthcare providers. This is very interesting for future research, and we hope it will provide the evidence as time goes on for the clinical guidelines. So without further ado, the webinar this evening is about health-related quality of life in children with bladder exstrophy epispadias complex. And it's going to focus on learning from experiences reported by children and their parents. And it's a great honour to have with us this evening our fabulous Swedish team, and the speakers are Gundela Holmdahl, and she's Associate Professor and Senior Consultant and Section Chief of Pediatric Urology at the Karolinska University Hospital. Before that, she held the same position for many years at Queen Silvia Children's Hospital in Gothenburg. Michaela Dellenmark Blom is another one of our presenters, and she's a Doctor of Medical Sciences, Associate Professor and Researcher at Sahlgrenska Academy, Gothenburg and Karolinska Institutet in Stockholm and Sweden. And she has throughout her career been committed to research of children with rare and complex malformations. And she specialises in the methodology and application of patient-reported outcome measures. She is today Director of a Centre of Excellence for PROMs in the Pediatric HealthCare Queen Silvia Children's Hospital in Gothenburg, Sweden. And then our third presenter is Elin Öst, and she's a Doctor of Medical Science at Karolinska Institutet in Stockholm, Sweden. And she's clinically active within the Pediatric Surgery and Urology unit, also at the Karolinska University Hospital. And she's following up children born with congenital malformations. So the presentation is going to look at the common disease-specific consequences of bladder exstrophy and epispadias in children, but primarily focus on describing experiences from a systematic literature review of health-related quality of life in children with this disease. This webinar is eligible for a ACMA accreditation for live attendees who fill in the survey within 2 weeks. And it's also kindly supported by ESPU. So thank you very much to all our presenters, and I'm sure we're all really looking forward to hearing your presentation this evening. Thank you very much for sharing your expertise with us. Gundela, you have the floor.
Yeah, thank you very much for this nice presentation. And I'm the first one that is going to take you through this webinar. So of course we have no conflict of interest, and I will just take you through first what bladder exstrophy is, or more precisely bladder exstrophy epispadias complex, the BEEC. Let's see if I can take this away so I can see my pictures better. Sorry. That's it. So a BEC, it's a wide spectra from isolated epispadias to classical exstrophy to cloacal exstrophy and its variants. You can see the epispadias where you have an open urethral plate, and in boys a short penis with a dorsal curvature, and in girls typically a bifid clitoris. In the classic bladder exstrophy, you also have an abdominal wall defect with a symphysis diastasis and the bladder plate opening in between. Going to the more really severe cases, you have the cloacal exstrophy, where you have the bladder split in 2 parts and the bowel opening in between, and with often spinal deformities. So, sorry. And we know all that it's very rare. It's a real rare disease with a prevalence of 2 to 5 in 100,000 born babies, and with geographical variations. The male to female ratio is about 1 to 2 to 1. Born with a bladder exstrophy means that you have a surgical journey ahead of you from the primary reconstruction of the bladder, urethra, genitalia, the bony pelvis, to the reconstructive continence surgery and secondary surgery of the genitalia. Lifelong follow-up is necessary to preserve renal function, to optimize the urinary tract and sexual function, and give a chance for reproduction. Concerning renal function, most individuals with bladder exstrophy are born with a normal upper urinary tract, but the renal function may be affected by the bladder closure and continence surgery, with risk factors as bladder emptying problems, upper urinary tract dilatation, reflux, recurrent UTI, and stone formation. Concerning incontinence, there are really few studies on long-term results. The literature are scarce and mostly reports from single centers. And of course, incontinence has been very difficult to define and makes it difficult to compare different studies. It is reported continence rates of up to 80% in children, which I really doubt. And it won't be better in the adults, where continence rates up to 40% under optimal conditions is reported. The majority will be catheterizing through urethra or stoma. The need of bladder neck repair and closures, catheter by stomas, bladder augmentation is great. In the end, an incontinence solution or a continent anal urinary diversion may be an option for dryness without catheterization. Sexual function is also a problem and also reproduction. In the females especially, it depends on the anatomy and the results of primary reconstructions. During upbringing and in adulthood, the girls mostly have a bifid clitoris still and a narrow anteriorized introitus. The majority will need revision genitoplasty in puberty. There is a 50% risk of pelvic organ prolapse, also in very young age. But up to 90% report sexual activity, but sexual satisfaction is affected with dyspareunia, anxiety about genital appearance, and incontinence. Fertility is reported normal, but pregnancy and delivery complications are common. Concerning men, the penis is short with a dorsal curvature. There are risk of strictures, fistulas, scars, a hypospadic meatus, post-reconstructions. There are risk of epididymitis. There are risk of erectile dysfunction and disturbed ejaculation. Some reports say that sexual activity is quite normal and also satisfaction, but there are really different results in all different studies. But we know that anxiety about genital appearance is great, and incontinence is a problem during sexual activity. Paternity is reduced, and there is often a need of artificial reproduction techniques. So, bladder exstrophy and the complex include severe urogenital malformations that affect lives of parents, children, adolescents, and adults. Among other factors for the health-related quality of life, continence, sexual and reproductive functions are really important, but also the ability to cope with it if it is affected. So in this webinar, we are going to talk about what we do know now about health-related quality of life in individuals with bladder exstrophy, why it is important to measure it in children, how to measure it, what we measure, and in the end, last but not least, a preliminary report from focus groups among parents and children, and about the first step to a condition-specific health-related quality of life questionnaire for children with the BEEC. I will soon leave the screen to Michaela, but if you want to dig a little bit deeper into this and read about bladder exstrophy, you can read Rare and Complex Urology, where we have a chapter, and there you can also find the references for what I have said today. So, Michaela, it's your turn.
Thank you so much. Let me see. Thank you, Michelle, for introducing us speakers. Thank you, Gundela, for your excellent introduction into this project. And thank you all for being here and listening to our presentation today. So to conduct a quality of life research project in children with bladder exstrophy epispadias complex, you need a dedicated, experienced, and multidisciplinary team. And I have the great pleasure to present our Swedish team who has made this project possible. In addition to the three speakers here today, we have Lisa Örtqvist, Associate Professor and Pediatric Surgeon from Karolinska University Hospital, Sofia Sjöström, who is Associate Professor and Pediatric Surgeon from Sahlgrenska University Hospital, and three excellent urotherapists, two of whom are also PhD students in this project. These are Ulrika Svenninghed, Cecilia Lindström Gruber, and Magdalena Boye. And in this presentation, I would also like to highlight Ulrika Svenninghed, as she is the PhD student who has been main responsible for conducting the focus group analysis results that we will present further on in this presentation. So we started this project several years ago, and we had great experience of the development of patient-reported outcome measurement, PROM, in other rare and complex conditions in pediatric surgery. And therefore, I would like to start to introduce the concept PROM. A PROM is a standardized questionnaire that collects data on health outcomes directly from the patient. According to international standards, a PROM should capture aspects that are important to the patient, using questions phrased in a wording that the patients themselves use, recognize, and understand. And this applies also to children. And in pediatric populations, parents are also considered as an important source of information regarding the child's health. Health-related quality of life is a core patient-reported outcome, which specifically refers to the patient's perceived impact of disease and treatment on the psychological, physical, and social functioning and well-being. And as we try to illustrate on this slide here, health-related quality of life can be measured using different measurement levels. The broadest approach is the generic measurement approach. It includes questionnaires that containing questions that are applicable to healthy people and to patient groups. This makes it possible to compare generic health-related quality of life outcomes between healthy people and patient groups. While disease-specific measurement approaches is a more narrow approach. This regards questionnaires that are sensitive to capture issues that are important to patients with a specific condition or disease and its clinical context. And disease-specific questionnaires are usually more sensitive to discriminate disease burden and capture clinical change following different interventions. So why PROMs? Why use PROMs? Well, as said, these instruments should measure outcomes that matter to the patients. And a valid and reliable disease-specific PROM will help us build an evidence-based and patient-centered care and treatment. So how do you then go ahead if you want to develop and evaluate a PROM? There is an international standard for this, and this slide shows the basic procedure. The first step is usually to start with a systematic literature review. You map out the existing knowledge of the field and you look at the existing instruments. What are their strengths? What are their weaknesses? Do these instruments capture the appropriate aspects in the patient's life? It helps to build a rationale for the second step. And the second step is something called concept elicitation. So what does that mean? It means that we need to turn to the patients themselves using focus groups or individual interviews and ask them about their experiences. So in our case, we were interested about health-related quality of life experiences. What does health-related quality of life mean to them? So the transcripts from focus groups and interviews are used to generate items for a preliminary questionnaire. Items that should capture aspects that are important to the patients and that keep the language that the patients themselves use and recognize. The preliminary item list then needs to be pre-tested to determine the patient understanding and to test the item comprehensiveness. So usually following a pre-test, there is a decision-making process regarding item exclusion, item revision, and item inclusion. This means that the preliminary item list is revised and it goes into a larger test called field test, where you test and establish the validity and reliability of the instrument in a larger sample of patients. Now, we believed that health-related quality of life is a key goal in care and treatment of children with bladder exstrophy epispadias complex. And we asked if there is a need for a disease-specific health-related quality of life questionnaire for these children that we can use in future research and clinical practice. So we started with the first step, a systematic literature review. This systematic literature review was published in 2019 in Quality of Life Research. Using a PRISMA-compliant protocol, we screened 603 articles and identified 21 articles addressing health-related quality of life in patients with bladder exstrophy epispadias complex. As viewed on this slide, the articles were published between 1994 and 2018, and 24% each considered either children or adults, while 52% of the studies had mixed age populations. Most studies came from Europe, a few were multi-center studies, a few lacked a control or reference group for comparing health-related quality of life. Interestingly, the external fallout that means, for example, patients that were lost to follow-up, was very high in some studies. So the median external fallout was 43%. This was very important information for us, as we need to ask who is really participating in health-related quality of life research in this population. And important for us to understand in our forthcoming project if we needed to have recruitment strategies to increase the representativity of the sample. We also noted that clinical and surgical information was sometimes sparsely documented, which could impede the understanding of the health-related quality of life outcomes. We also observed that 36 health-related quality of life assessments had been used in this population. Mostly this had disregarded instrument to measure aspects of health-related quality of life, such as mental health or sexual health or functioning. 9 generic health-related quality of life questionnaire were used, and self-designed questionnaire without any reported validation were also of use. But we did not identify any condition or disease-specific questionnaire that were valid and reliable for patients with bladder exstrophy epispadias complex. So what about the outcomes? Well, as the studies had investigated health-related quality of life differently, outcomes were also differently reported. But we detected some patterns. Total and physical health seemed impaired in children, and psychosocial health-related quality of life seemed negatively affected in the studies, including integrated age samples, and impaired body perception and sexual health or functioning are found in adolescents. We also conducted a meta-analysis, but as seen on this slide, only 3 studies could be included in the meta-analysis, and this can be seen as a quality indicator of the studies, as many studies lacked sufficient data to be included in the meta-analysis. From the data from 3 studies, the pooled estimate of health-related quality of life showed that health-related quality of life was lower in children with bladder exstrophy epispadias complex, but all results in the meta-analysis were not significant. Main factors associated with health-related quality of life impairments were urinary incontinence in all ages, adolescence and increased patient age, catheterization, and dissatisfactions with genitalia in the mixed age populations. So in conclusion, we found impaired health-related quality of life in patients with bladder exstrophy epispadias complex, but we could not draw definite conclusions. We did, however, identify a number of different recommendations to improve future research, and we were lucky to be able to incorporate these in our forthcoming project, because this study built the rationale to continue with the development of condition-specific health-related quality of life questionnaire for children with bladder exstrophy epispadias complex. So we knew that the second step was focus groups. We needed to gain more insight into these children's perspectives, ask them questions and listen to their narratives, try to enter their life world and see their view. So what is a focus group? A group interview with distinguishing feature of group interaction to encourage in-depth discussion. The participants have experience of the same defined area of interest. In our case, health-related quality of life experiences after being born with bladder exstrophy epispadias complex. A focus group takes place under the guidance of a moderator who facilitates the discussion using predefined questions. It also takes place under the presence of a field assistant who takes note on group interaction and support the participants practically. And now it is turn for my colleague Elin Öst to present how we established the project in Sweden and the initial results.
Thank you, Michaela. So, Yes, so the first thing we really need to think about was, of course, the ethics. To do this kind of research, you really need to think about the ethics. And when we received the first answer to our ethical application from the Swedish Ethical Review Board, they were very hesitant about letting us interview children and adolescents in groups. Their motivation was that this is an intimate and sensitive topic, and we agreed, of course. So we had to carefully explain the methodology, that all personnel in the team were trained for this, and also what kind of backup and psychological support we could offer if anyone needed after the focus groups. And our strongest motivation was clear. If we couldn't talk about this, who could and who should? So we had already got positive responses from several families who wanted to be included in the study, and we felt that we needed to keep on, and we wanted to keep on. So after this amendment, we received an approval. Our plan was to recruit 4 to 5 children in each group. And as you can see here, we divided children and parents into groups according to age and sex. And the families who were enrolled in our follow-up program received a phone call from our urotherapist. And the urotherapist is a key person in the team, and we wanted the families to feel safe when we took the first contact. And if the families were interested, we sent them more information and of course gave them time to think this through. And the interest was really large. 37 participants are included in the study. There are 14 children and 23 parents. And as you can see here, it's a mix of different patients, which Michaela told you earlier is really important. So moving on to the focus group. The focus group started with a presentation of all participants, and we explained to the children where their parents were and that they could go to them whenever they wanted to. We also said that everything that was told in the group should stay within the group. It was okay to talk about parents about it, but no one outside. And if there was something that they didn't want to talk about, it was also okay to be quiet. So the focus group started after the presentation with the moderator starting by answering questions. And I should also say that none of the moderators or the field assistant knew the families. They were not in their medical team. So the moderator started by answering questions, and well, then the discussion was ongoing. And both the moderator and the field assistant made sure that all topics were that we were interested in were discussed. And we also had a secret box in all focus groups where the participants could write down anything that they wanted to share that they thought might be of interest, but they didn't want to say out loud. So during the focus group, we took pauses, and the focus groups were recorded, and afterward they were transcribed word by word. And 2 weeks after the focus group, we called everyone to just make sure that they were feeling all right, and if they wanted to have any further contacts, and if there were any questions. And then the next step is the analysis. And the analysis starts with reading the text over and over again, and then finding meaningful text, and then trying to categorize the results with similar content, and finally creating categories. And today we are going to present 5 of those categories for you. Starting with the first one, which is living with the choice of openness about BEEC. And this category is followed by 5 subcategories, and those are experiences of choosing to tell others or not, absence from school, choosing whom to tell and how much, having a parent as a spokesperson, and the choice to show or hide body parts or aids to others. And I'm going to read some citations for you. Our son also wants to be liked, but when he takes steps to socialize with others outside of his regular friends, and they start asking questions, they are no longer welcome. And another parent said, our son was very open about bladder exstrophy. As you say, they've been away for a very long time due to surgery, so we have to talk about it. Otherwise, it will be like you say, they just call and call and call, wondering and wondering. He doesn't want to show his protection that he has. He doesn't want to show anything. And as one child said, I don't think I've explained to anyone what bladder exstrophy is. Moving forward to the next category, which is social relationships, interactions due to BEEC. And this follows by 5 subcategories. Others wonder about BEEC, the choice to respond to questions, the importance of friends, and being or feeling vulnerable in situations, and to meet others or not. And here are some citations. He answers questions about bladder exstrophy, the ones he wants to answer and the ones he doesn't want to. He says, I don't want to answer that. Now we're going to play, sort of. Has happened. Peace comes in the shower. It's like, oh yeah, now it smells. People just, oh no, now it smells like pee. Someone has peed. And then people usually look at me because they know I have a hard time holding it in. There are 4 girls who are about the same age who meet at camps for children with BEEC and so on. And they mean quite a lot or a lot to each other. And the next category, psychological impact due to BEEC. And this one follows by 3 subcategories. Thoughts and feelings about looking different, thoughts and feelings related to BEEC, and need to feel safe. And this is what some of the participants said. But then, as I said, he wants to be like everyone else and not stand out in any way. Leaking is probably the hardest part. Yes, he says my son, can hate his body, but there are very big scars, or like it's very clear. Okay, so Michaela, I'm leaving the floor to you now. You are still muted.
Thank you, Elin. I will now continue describing some parts of our results. So what else health-related quality of life experiences the children with bladder exstrophy, epispadias complex, and their parents describe? They described experiences about functioning in environments outside home. This regarded, for example, public bathrooms or nature. Some children describe that they wanted to know where the toilets are in new places, in new buildings, airplanes, trains, and they needed to plan or they needed to avoid such situations if if they didn't know where the toilets were. They described experiences of standing in line, and sometimes these experiences included difficulties standing in line, especially if it took time. The children and parents also described experiences to have or not to have a school environment that works well with bladder exstrophy epispadias complex. This environment included the physical environment, such, for example, like having lockers to keep their supplies and aid in, but also the psychological environment, such as having an understanding by teachers from school, the understanding that they sometimes need to interrupt or adjust their schedules or plan to have toilets for bladder emptying. The experience also included time, energy, and plans that they needed to make to participate in leisure activities. On this slide, you can see 3 quotes. A child who said that, for example, it takes 40 minutes to stand in that line to the Tivoli, so we can make it. And then when it is just to be our turn, I need to tell my parents that I need to visit the toilet, and then we need to restart standing in line again. A parent said that there is no building where my daughter cannot tell where all the toilets are. And another parent said, it is important with a school that functions well from the perspective of bladder exstrophy epispadias complex, that there is an understanding he needs to visit the toilet and that you consider it when doing excursions, adapt the time schedule and ensure there are toilets available. The last content area we are going to present today regards experiences of adaptations the children needed to make due to bladder dysfunction. This regarded, for example, perceived impact during evening and night times, such as the children needed to go up at night to empty the bladder, they needed to adjust their evenings, for example, with restricted fluid intake, and experiences of having continence material during night. They also described a dependency to follow time schedules. They described experiences of clothes, adjusting their clothes, having specific preferences of clothes, and thinking of bringing extra clothes in case of urinary leakage. Here you can see 2 quotes from the focus group. A parent said that my child has expressed that quality of life with Friday and Saturday evening is affected because she doesn't drink during evenings, and then her little sister or her friends who are with her are drinking soft drinks. And another parent said that when we look at clothes and clothes for sports, he has very distinct wishes and preferences that there should be pockets with zippers because then he can bring his material in the pocket. So you have been listening to parts of an overall project. There are much more data regarding the children's health-related quality of life, coping resources, experience of care and treatment, and family impact. But in this presentation, our take-home message is that we have followed current standards of PROM. We have conducted a systematic literature review and a focus group study in children with bladder exstrophy epispadias complex that reveal their possible physical, psychological, and social impact in life. And this information is now being used to establish content validity of a health-related quality of life questionnaire for these children that we hope can be used in future research and clinical practice. And now I will leave over to Gundela, who will tell you what is next.
Oh, thank you. Love working with you, Michaela and Elin. So what's our next step then? It's the item development to create that preliminary condition-specific health-related quality of life questionnaire. And in the next phase, we have to have a pilot test and cognitive debriefing, and in the end, also the field test. Our dream is that if we are able to create this, that we could be able also to translate it into further languages, if it's possible to use it even internationally. And what I think also is very interesting that we are trying to make another project besides this that we are focusing on coping in children with bladder exstrophy. Thank you so much. Was that the last one?
Yes.
Yeah, that was. Any questions? That's where we were.
Thank you so much. Thank you all for your very nice presentations. I very much enjoyed listening to them. I would indeed like to open up the discussion section of the webinar. So I would like to invite all the attendees that have a question to type in their questions in the questions field. So you should have a little Q&A button with a question mark on it. That's where you can type in your questions, and then we can read them out loud and answer them. Oh, I can see that one person has already sent in a question. So if one of you would like to read out the question, then they know what we're talking about.
Yeah, I can do that. How do children with bladder exstrophy epispadias complex perceive the impact of their condition on their daily life? And what specific challenges do they report? What strategies can healthcare providers still implement to better address the emotional and social needs of children with BEC and their families? Michaela or Elin, do you want to answer?
Well, these are three big questions. So I think that in the long term, our project will help to answer these questions properly. I think to be able to answer those questions, you need to have the right questions from the beginning, and that is part of our project. I think that, and Elin, correct me if I'm wrong, but a main theme in our focus group study was the first category you presented on the choice of being open about their condition or not, and the possible social impact that it can have. Would you like to add on that, Elin?
Well, yes, I agree. That was a big part, whom to tell or not to tell, and how much to tell, and finding support in other persons around you. And I will also say that specific challenges. One of the big part that we found out was that incontinence is a big struggle for a lot of persons, and coping with that, and yeah, sometimes I felt like most of the days or their daily life were about handling incontinence.
I also think that what we can see in the focus group listening to their experience, is that next to healthcare, the environmental support around the child is very important. Like, very many parents told us about the meaning of the significance of the school. To have a school that functions well with their condition was very, very important. And outside that, also the family is very important for the child, because the parents took a particular responsibility to enable them, for example, to participate in sports, to participate in excursions with other children. So the support we can have, the collaborations with schools, and the support to parents will probably also be very important to support the children's quality of life.
Yeah, it was also about what strategies can healthcare providers give, and I think it's the big thing is to listen and give time, and also make it possible for these patients and families to meet. I think it's also very important to, within the team, have the psychologists and social workers, so the psychologists know what it's about being born and to live with bladder exstrophy.
Yes, this is also something that came through in the focus groups, that being able to explain if you want to is very important for the children. The experience around talking about it was very different in different families. Some have kept it more like not a secret, and some were very open about it. But that to communicate around the condition with the parents and the child, they will be able to do it better with others too.
Thank you. I can see another question has come through in the chat. So somebody says, I am a pediatric general surgeon practicing in a resource-poor area of South Africa for the past 30 years. In 1997, we wrongly assigned female gender to a boy with bladder exstrophy who had a very small phallic tissue. Have you ever faced such a situation?
I know, I mean, it's a big issue in the boys with the cloacal exstrophy, that you have reassigned them to girls, but that was decades ago in Europe. I think it was about 25 years ago, we had a really big discussion in Gothenburg where we really consulted everyone, because one of us wanted to change the sex to a girl in a boy with cloacal exstrophy, and we ended up that he is still a boy. And I think that was terrific, and that was the last time that we had a discussion about it.
Because I can imagine that if you do change the sex because of anatomic differences, you will end up with severe psychosocial disorders when the child grows up to be an adolescent, perhaps.
Absolutely. There's from Francisco de Badiola. Thank you all. Is it your opinion? What is your opinion about to send all patients to special centers to be treated? I can just tell you, yes, I think in Sweden we have centralized the core diagnosis in pediatric surgery and then pediatric urology, and we decided there was going to be one center in Sweden, for example, and even though we don't have very, very many, but just living with that, with the centralization in Sweden, we have won so much. I think it's very important just to continue working to centralize these very, very rare conditions.
But how do you recommend doing so? I mean, I think it's all good to have a centralized care because then you have an experienced team. But if somebody lives far away from that center and something occurs and the patient needs to go to an emergency room and they are not very familiar with the condition, how do you proceed then?
Well, I mean, we have many channels today to take contact with a specialist center and where you really have the knowledge. So I think today it's not a very, very big issue, but it is a problem with the long traveling for the families, absolutely.
But we sort of had that problem already in Sweden because Sweden is a large country with a small population, and so we already had kind of that problem.
Yeah, it's a good thing that today we can just contact each other easily through the internet.
Absolutely.
So make sure to use our CPMS if you want to share.
But listening to parents and children, for example, in the focus group, they appreciated the competence of the specialist. That was also something that came through. It was so important to see someone who has experience and knowledgeable, and they connect so much to the pediatric urologist and to the urotherapist. So also a system that can create continuity with the team is very important for their quality of life.
Yes. I'm just reading through the comments section to see what about the specialist move where the patients were born?
I don't think that's a good idea because you need the team. I think it has been very good. I mean, we've been traveling, the surgeons before in Sweden. Now we are in one place together with the nurses, the ward, the surgical team, and with the urotherapists and the psychologists. It's great, I think.
Yeah.
I think there's another interesting question that I wonder if the older patients of your focus groups, 13 to 18 years old, were they 4 girls and 4 boys, verbalized any concerns regarding their sexuality, romantic interfaces, etc. And I think you can tell us a little about, because the big problem group is the teenagers, to get them to talk in the groups.
Well, yes, I think these experiences were also reported in the group, but also in the secret box that we had, where they could place experiences they thought were important for us to know, but they didn't want to speak about in the group. So the teenagers, for example, were thinking a lot about the future, even about parenthood and about sexual relationship. But also parents brought up that, and parents brought up that for younger children, because they want, if I remember right, Elin, you can help me here, but they expressed also a need to discuss these issues very early in the children's life with healthcare. Not late when it appears, but early, because the children described, and the parents too, that they turn to the parents to talk about these issues.
Yeah.
So
sorry. We also found out that having others in the same situations could really help to talk about those questions. And there were things that they didn't want to share with us, but we understood that they were talking about this in other forums, like chat forums and so on, with each other. And that was helping a lot.
So we put it under the category growing up with bladder exstrophy epispadias complex, because it was integrated with becoming older.
Another question here is about families when you are far away, like brothers and sisters. Yes, that can be challenging.
And I can see another question. Thank you for the presentation. I enjoyed it. I am from Nigeria. Aside from bladder exstrophy epispadias complex, do you have experience in assessing health-related quality of life in other pediatric surgical conditions?
Shoot, Michaela.
Well, I'm biased as I am a quality of life researcher and been in pediatric surgery for many years. Yes, we study, and we do it in many collaborations between Sahlgrenska and Karolinska in esophageal atresia, in spina bifida, in abdominal wall defects, in anorectal malformations, so in many conditions. And I think one of the important experiences that I had was with esophageal atresia, because the response of the development of a condition-specific questionnaire has been fantastic. It has now been translated. It came from Sweden and Germany. It has been translated to 22 countries. And that makes it possible to standardize an outcome measurement for rare and complex, for children with rare and complex condition. Instead of using 36 different questionnaires, we can use a questionnaire with proven importance to the patients and standardize and compare results. And I think that adds value to these children.
Yes, definitely. Because when you look at the PROM studies that have been done for bladder exstrophy patients, are there questionnaires that come by, that you see come by often? Like, for example, for sexual health or something? Are there questionnaires that are commonly used?
Yes, yes, there is.
But they are just not specific for bladder exstrophy, of course.
No, it doesn't mean that they are not proper, but we don't know how they function and if they ask the question in the right way. It can also be a part of an overall measurement. So I think this domain should be seen in relation to others. What you though can notice also in the previous studies is instead of collaborating in multi-center studies, they enlarged the samples with integrating different ages with each other. And that can be positive in some ways, but I think one disadvantage is that you lose the sensitivity, for example, to study adolescents specifically, and issues that are important in certain phases in life. So I think that in the future, it will be very important to collaborate and to get an understanding of the different phases in life instead of mixing different ages.
Yeah, I can imagine. That would be good. Thank you. Maybe one last question, because somebody thinks that your institute probably has longest follow-ups for many congenital anomalies. What is your follow-up period?
Our follow-up period is we admit them to adult services between 15 and 18 years of age. But now we are really trying to have this very good transition and to continue to follow them in adult life. So we follow them, and we just enter the registry of bladder exstrophy for the ERN, and I really hope that that will have a positive effect on this.
Yeah, I really do too. Thank you. I think that's a good note to end this webinar with. I would like to thank you very much for this interesting presentations and the discussion. And thank you to the attendees who have joined our very first webinar of the year. Just quick things, there will be a survey sent out to everybody who has joined live. So if you fill in the survey within 2 weeks' time, you will receive the EACME certificate. Make sure to follow us on YouTube, because I will be sending out the link of the recording of the webinar tomorrow to everybody, and then you can watch it over there on our YouTube channel. You can also find everything on our website about the past and the future webinars that we've got scheduled. So yeah, I think that was everything I would like to say. Thank you again, and I would like to close the webinar. Have a good evening.
Thank you.
Thank you.